we're going to move now to Peter Johnson. Now, Peter, I'm delighted you've spared the time to come and talk to us. I know you're busy always, but particularly so at the moment, because it's important that we have a plan. And I know that you and other members of your national cancer team have been looking at the effects of COVID, and we'd be very interested to hear from you exactly what the proposals are in relation to prostate cancer and cancer in general. So, Peter, thank you.
No, thank you very much indeed for the invitation, and I hope you can see the slide in the full screen mode like this. Thanks for the invitation to talk today. One of the reasons for wanting to make sure to join you is that prostate cancer is, as you've already heard, one of the tumor types which has been most profoundly affected, certainly in terms of the numbers of people, by the pandemic. And clearly the pandemic has left a huge trail of destruction in its wake in all sorts of ways, and we continue to live with that even today. But I wanted particularly to talk a little bit about the data, and you've heard the data that's in the current report of the audit, and to bring that a little bit up to date, and then to share with you some of the thoughts we've been having about how to try and remedy the situation and how to try and move things forward. And to be honest, I think this remains a relatively contentious question, and there are quite strongly held views on both sides, but I'd be very interested by the discussion and to see what you think. So, as you've already heard, we saw a very sharp fall off of referrals for prostate cancer. This is our 2-week wait referral data, and it fell to around 40% of the normal levels at the beginning of the pandemic, as we've already seen, and they have been some of the slowest to recover. And what this graph shows you here is the comparison of the October 21 figures to the figures in the preceding 18 months, so March 2020 to October of this year. And we've set out all the different types of 2-week wait referral pathways. And you can see that prostate is nearly bottom. We've overall seen only 84% of the expected numbers of referrals that we would have expected to see in that time. Although, as you can see from the blue bar here, the referrals have been running at more or less normal levels in the most recent month for which we've got data in October. Nonetheless, in aggregate, we've seen significantly fewer referrals during that time. And you can also see that things like breast cancer and gynecological cancer and GI cancers up on the left-hand end of this diagram are running at significantly higher levels, 110, 115, 120% of normal. And this varies quite a lot by geography as well. And there are some parts of the country where we're still seeing referrals which are consistently below the pre-pandemic baseline. And looking at why that is, we looked at the numbers of PSA tests being done, and not surprisingly, they exactly track the figures that Julie's shown you for the numbers of referrals and the numbers of diagnoses. A big fall off at the start of the pandemic, a gradual recovery to the winter of last year, and then largely sustained through the second wave. We know that many patients are still to come forward. And one of the things that we've been able to look at with the cancer registries is the number of emergency presentations. And in some ways, this is reassuring, at least for prostate cancer. You can see here, this is the absolute number of emergency presentations split out by tumor type between April 2020 and March 21, which is the most recent month for which we've got good registry data. And you can see that taken in aggregate, actually, we saw fewer people presenting as emergencies with prostate cancer than we would have expected in a normal year. Conversely, you can see up at the left-hand end, GI cancers and cancers of unknown primary were coming through in rather larger numbers. So over the whole period, the number of emergency presentations is lower. What I do have to say, though, is that in the most recent quarter for which we've got information, we did see a rise in emergency presentations with prostate cancer. So I'm slightly nervous that this trend may be starting to reverse now. That is only one quarter's worth of data, however. Perhaps more importantly than referral levels, it's the numbers of people who've started treatment. And again, you've seen very, very helpful data from the audit, looking at treatment broken down by modality and the levels of activity. And again, this is really just to update those figures to the latest, for which we've got data from September of this year, going back to the beginning of the pandemic. And you can see that the overall aggregate is 81% of the normal numbers of people we would have expected to start treatment. And this, to me, I think is the most important point. That's around 12 to 13,000 men in England who in the normal year would have started treatment for prostate cancer, who have not done so this year. So a downturn in referrals I'm calm about, but a downturn in treatment numbers is obviously a much more anxious business. And that's what the main reason for wanting to try and correct that. If we look at the staging data, and Julie's already shown you some staging data that's in the report, and again, this is slightly updated using data from the rapid registrations data set that the cancer registries are now able to assemble. What you can see here is we've broken it down on this slide by stage 1, stage 2, stage 3, stage 4, the unknown figures. And that's broken down by the successive 5 quarters for which we've got data. So starting in April 2020 and coming up to June 2021. And what you can see is that the early stage cancers took a big dip early on and then have progressively recovered to around 80% of normal, whereas more advanced stage cancer took less of a dip, and not surprisingly, because these would be men who had symptoms and were therefore very much more likely to present even in the face of the pandemic. And those numbers have recovered more substantially, so that we're just above the normal numbers at stage 4, but really only just in the last quarter. So overall, you can see a big downturn, as we already said, in early stage cancer, and cumulatively, if we look at the bottom here, we can see that it's around just under 70% of people with stage 1, 2, and 3, and just under 90% of people with stage 4 cancer that we've seen and diagnosed during the pandemic. And obviously the concern is that if this goes on for a significant length of time, that we'll see more people coming through with stage 4 incurable disease, and that we will miss the opportunity of cure for people with potentially locally advanced disease, which may progress during the time that we're still trying to find them. And I think this is not just about PSA testing or early stage disease. I think this is across the piece, but clearly the main anxiety and the main potentially reversible problem is that of people with potentially locally advanced disease. We have done some work on implementing the best practice pathway, which was something that we'd got set up and which was running in a number of areas prior to the pandemic. And again, as you've seen from Julie's data, a number of changes have been taking place as that pathway has been progressively rolled out, and certainly some of the places which have implemented it most effectively have seen big drops in the length of time that it takes to move from a referral to starting treatment. Particularly the nurse-led triage to work with primary care to make sure that patients are prepared as effectively as possible and prepared to go straight to test. Lots more use of multiparametric and biparametric MRI to guide biopsy, and clearly bringing that in as early as possible as a means of determining the biopsy approach has been extremely effective in the places that have managed to do that. And trying to get through the MRI and a biopsy, if not on the same day, then a very short time interval afterwards, certainly within 9 days of the referral, so that the discussion and the discussion of treatment options can happen within the anticipated 28 days of the referral. And interestingly, looking at the imaging data set, we've seen a significant increase in the numbers of multiparametric MRI studies on the prostate that were done in 2000 compared to 2019, even in the face of that downturn of referrals seen in the pandemic. A significant increase in the use of that technology. And that feels like a very important development and something that we would want to encourage. And again, interested to discuss how we might go about doing more of that and doing it more rapidly. So in trying to think about the things that we need to do, as I say, this is not without some controversy, and certainly when we've talked to clinicians in cancer alliances and the BAUS, people in BAUS, there is some sense in which people have told us, well, look, the pandemic is not over, primary care is extremely busy, we've got a huge elective backlog. Do you really want to be driving more presentations of prostate cancer? To which I think my response is, well, I think amongst those 13,000 men are people who may move from curable to not curable if they're not discovered in a timely way. So I think it is incumbent on us to try and do everything that we can to discover this illness and to make sure that we're doing everything we can to minimize the effects of the pandemic that everybody is familiar with. And I know there was a discussion about this at the BAUS meeting, I think it was last week, and it would be helpful perhaps to pick up on what the feelings were in that. So in terms of what we would like to do, firstly, obviously raising awareness, and Stephen and others have done a superb job of keeping this in people's minds, even when there is so much else going on. And we're working with Prostate Cancer UK, who have been extremely effective at raising awareness, and have got this a very useful risk calculator on their website. So we're working with Prostate Cancer UK to do more to raise awareness of the risk, and we're helping them to develop a campaign for early in the new year, hopefully once the heat of the latest wave of coronavirus is over, to start encouraging people to be aware of their risk level and to consider whether they need to seek help. We're also trying to get leaflets and information videos out to some of the big vaccination hubs, because we know that at least some of the demographic we're looking for will be coming through having booster vaccinations. Obviously, the older end of that group have largely been through now, but we're working to try and get some information out as quick as we can to the hubs, so that again, this is about raising awareness, making people aware of what their levels of risk might be, and considering whether they ought to seek help for that. We're working with the cancer alliances, particularly where we've seen the lower referral rates and the slower recovery, to try and see what we can do to target those groups of men who are most at risk, and to try and support some proactive case finding. And we're working with some of the very important community groups who are very good at liaising and raising awareness. We're trying to work with primary care. Obviously, primary care is under massive pressure at the moment, but once the acute pressure lifts, we're going to resume that work to try and help them with the prostate cancer risk management program, and also try to improve the pathway and to put more resources through the cancer alliances, again, into the nurse-led triage in some of the alliances, helping to implement the best practice pathway, and furthermore to make sure we have a diversion of funds into the relevant diagnostic and treatment capacities. So lots of work going on, but certainly very interested to hear the discussion about if people have ideas and thoughts about what further we might do. So I will end at that point.